The human eye is a constrained anatomical space. Because there is no room for expansion, any cellular proliferation threatens the delicate structures required for sight. The moment a mass is detected, the clinical clock starts. A practitioner must accurately differentiate a benign anomaly from an aggressive malignancy before those cells breach the globe and metastasize. This image shows the two distinct demographic pathways that dictate our entire diagnostic algorithm. On the left is a dark, vascularized adult tumor, and on the right, a bright, calcified pediatric mass. In the adult patient, the challenge is sorting the harmless nevus from a malignant uveal melanoma. In children, the stakes shift. The diagnostic challenge becomes recognizing a retinoblastoma at the very first sign of a white pupillary reflex, known as leukocoria. Mastering ocular oncology requires absolute precision in anatomical localization and a strict adherence to validated clinical risk biomarkers across both of these age groups. We begin with the adult pathway. Choroidal melanoma is the most common primary intraocular tumor, typically presenting in patients between the ages of 40 and 60. To understand the malignancy, we first look at the benign baseline. This image shows a typical choroidal nevus, a flat greenish-brown pigmented lesion near the optic nerve. Note the diagnostic hallmarks: entirely flat, under 5 millimeters in diameter, with a complete absence of associated blood vessels. The clinical tension lies in objectively quantifying exactly when a stable cellular cluster like this begins to transform into a malignant threat. To calculate that risk, oncologists use a specific framework known as the TFSOM-UHHD criteria. The first variables are thickness over 2 millimeters, subretinal fluid, and clinical symptoms like vision loss. The remaining factors are orange pigment on autofluorescence, a margin within 3 millimeters of the optic disc, ultrasound hollowness, and absence of a halo or drusen. Finding 3 or more strongly indicates melanoma. Now examine this photograph of a confirmed malignant choroidal melanoma. The structural differences from the nevus are clear. We see an extreme dome-shaped elevation and prominent overlying retinal blood vessels actively feeding the mass. This geometry is dictated by the eye's anatomy. The rigid outer sclera restricts outward expansion, forcing the tumor to grow inward toward the center of the eye. This creates immense internal pressure, eventually causing the tumor to rupture through Bruch's membrane. We call this the collar button effect, yielding a distinct mushroom-like shape. Recognizing this anatomical breakthrough is a critical step. Once Bruch's membrane is breached, the tumor's intrinsic vascularization is exposed, increasing the risk of cancer cells entering the bloodstream and spreading beyond the eye. Malignancies in the posterior pole are common, but we must also evaluate the anterior segment, specifically focusing on the ciliary body and the iris. Ciliary body tumors are notoriously insidious. Because they are hidden behind the iris, they often present late as unexplained astigmatism or as localized cataracts or total lens subluxation. When evaluating visible lesions on the iris, we use a different diagnostic framework to assess the risk of transformation, the ABCDEF criteria. We evaluate age, specifically younger patients, we look for blood in the anterior chamber, known as a hyphema, and we note the clock hour, as tumors located inferiorly carry a higher risk. Let's analyze this image, which demonstrates the D criteria.
D stands for a diffuse growth pattern. This wide-spreading, irregular border across the iris stroma is a primary warning sign of aggressive cellular spread. Next, observe this photograph illustrating the E criteria, showing clear architectural destruction. E stands for ectropia. The tumor mass physically pulls and distorts the pupillary margin, warping it away from its normal circular shape. Finally, we evaluate the F criteria in this high magnification view. F stands for feathery margins. A jagged edge like this indicates active, unencapsulated tumor infiltration directly into the surrounding healthy tissue. Out of all these factors, the presence of blood and a diffuse growth pattern are the absolute most powerful predictors of malignancy, requiring immediate surgical evaluation. When diagnosing pediatric patients, typically toddlers aged 2 to 3, our focus shifts entirely. The sinusites, but retinal progenitor cells.
Here, we are hunting for retinoblastoma, the most common primary intraocular tumor of childhood. every practitioner must instantly recognize the hallmark clinical sign shown in this photograph, leukocoria, or a white pupillary reflex. Notice the bright, white, highly vascularized tissue. While adult melanomas are dark, this retinal mass reflects light directly back through the pupil. A white reflex requires immediately ruling out several critical differentials, including congenital cataracts, persistent fetal vasculature, and toxocara infections. If it is a retinoblastoma, it will follow one of two distinct growth factors. The first is endophytic growth, where the mass expands inward from the retina into the vitreous body. The second is exophytic growth. Here, the tumor expands outward into the subretinal space, physically peeling the retina away from the choroid and causing secondary retinal detachments. Clinical visualization alone is not enough. You must confirm the pathology with radiological imaging. This axial CT scan of the orbits provides definitive radiological proof of the disease. The explicitly bright, dense calcification within the globe acts as an objective marker, definitively separating retinoblastoma from other pediatric masses. If a child presents with rapid, progressive proptosis instead of leukocoria, the primary differential shifts to rhabdomyosarcoma, an aggressive orbital muscle tumor. Ultimately, any uncertain retinal or vitreal white lesion represents a zero-tolerance threshold for observation. The risk of rapid, lethal metastases in these young patients is simply too high. Effective oncological management requires committing these divergent clinical pathways to memory. Let's look at the final comparative decision matrix. For the adult uveal tract, we track the initial pigmented lesion through the TFSOM-UHHD or ABCDEF criteria, calculating the risk profile before determining an intervention. Depending on those variables, management ranges from rigorous observation for small, stable lesions to plaque radiation or enucleation for advanced disease. By contrast, the pediatric retinal pathway leaves no room for observation. Leukocoria triggers immediate imaging, which flows directly to urgent systemic intervention. Pediatric management relies on immediate ophthalmic oncology referral for radiotherapy or chemotherapy to ensure survival. Successful management depends on precise anatomical localization, the recognition of demographic warning signs, and strict adherence to these validated clinical risk frameworks.